Thank you.
All right, everyone. Thanks for joining us this evening. Tonight's webinar will be hosted by Dr. Madeline Tadley on understanding carpal tunnel syndrome. Dr. Tadley is one of our hand and upper extremity surgeons here at Rothman Orthopaedics, and she sees patients in our Northeast Philadelphia office, Princeton, New Jersey, and Bordentown, New Jersey. Just a couple of housekeeping items. Please feel free to enter your questions in the Q&A box during the lecture, and Dr. Tadley will take some time to answer them at the end. Please keep your questions as brief as possible, not too specific to your case, just so that we will be able to get through those, through all of the questions that come in. If you have any questions during it, please feel free to send a chat to me as well, and use the Q&A box too. So Dr. Tadley, you can take it from here.
Great, thank you. And thank you everyone for coming this evening. My name is Madeline Tadley. I'll be talking to you today about carpal tunnel syndrome. Just a little bit about myself before we get started. I went to undergrad in Georgetown, came back to Philadelphia, and went to med school and did residency at Jefferson, and was lucky enough to be trained by the folks here at Rothman. I went to New York for fellowship where I studied hand and upper extremity. And as a Bucks County native, I was very excited to come back and serve in this area. Like Natalie mentioned, I see patients in Princeton, Bordentown, and the Northeast office. I operate at the Jefferson Navy Yard Surgery Center in South Philly, as well as the New Jersey Surgery Center in Hamilton. I also have hospital affiliations at Capitol Health and take call at Robert Wood Johnson. Today, we'll be discussing many different concepts about carpal tunnel syndrome. We will first go over the form and function of nerves generally and what happens when a nerve is under pressure or has compression. We'll go over the details of carpal tunnel syndrome, the symptoms of carpal tunnel syndrome, how it's diagnosed, and what treatment options. Finally, we'll wrap up with what to expect if you're having carpal tunnel surgery. So first, the form and function of nerves. Nerves are responsible for transmitting electrical signals from the brain and spinal cord into the extremities. They can either provide information about sensation or send electric signals to activate muscles. Some nerves do both of these things. When a healthy sensory nerve is working, it picks up a signal from the environment in our skin and transmits that information up the nerve into the spinal cord and brain. A healthy motor nerve would receive a signal from the spinal cord or brain and transmit that information down the nerve to power that muscle. Nerves themselves are structured with layers of protection and insulation, and they also have their own blood supply. It is not dissimilar from electric cables that power our devices. So as you can see here, there are many electric fibers that are surrounded by layers of insulation. They are packaged in groups that form a cable. And similar to an electric cable, nerves have these layers of protection. The individual or basic unit is called the axon. That is acting like the individual nerve cable or electric cable, and that is surrounded by a layer of insulation called myelin. These groups of axons are packaged together to form a fascicle, and each fascicle is grouped to form a nerve. And as you can see in this diagram, there are blood vessels that exist within that insulation system to provide nourishment to the nerve. Now we'll go over what happens when a nerve is compressed or has pressure on it. Pressure on a nerve decreases its blood supply, and over time, it can wear out the layer of insulation around a nerve. So if anybody on the webinar crosses their legs like I do, and I put pressure on the outside part of my leg, the nerve that travels on the outside part of my knee has its blood supply compromised and my foot falls asleep. Generally, when I relieve that pressure, the sensation comes back. Same thing happens in nerves all over the body. So this is demonstrating increased pressure on a nerve, and you can see that the blood vessels in the layers of insulation can get closed down. If this happens over time, the insulation around the nerve, demonstrated here in this blue, can start thinning out. If this happens for even longer amounts of time, prolonged and severe pressure can cause nerve damage. You can see that the axon, that fiber cable that once traveled in the center of the nerve, is starting to break down. This happens when nerve pressure goes on unchecked for a very long amount of time. As we talked about, when a healthy nerve is working, it provides sensation and motor function to muscles. When there's pressure on it, both of those functions go awry. You have abnormal sensation, and this is experienced as numbness and tingling. It possibly can be painful to you too. When the electric signal is not getting to the muscles in the nerve, you can also experience weakness with nerve pressure. Carpal tunnel syndrome specifically is when this process happens to the median nerve at the level of the wrist. The median nerve starts all the way up in your neck, and it travels down your arm, into your forearm, and across the wrist to provide sensation and power the muscles in the hand. Demonstrated here, you have the median nerve in yellow. It's crossing the wrist joint, and it's providing sensation to the thumb, index, long, and half of your ring finger, seen in this shaded photo. It also sends a branch to the muscle at the base of your thumb, kind of the meaty part of your hand called the thenar eminence, and that's responsible for opposing your thumb. It's called the abductor. This is a cross-section of the carpal tunnel, and if I've seen you in the office, you may have seen my more rudimentary drawings of this. I think of the carpal tunnel like a box. The floor and the sides of the box are formed by the bones in your wrist. Those are called the carpal bones and how carpal tunnel syndrome gets its name. The top of the box is formed by a ligament. Inside of the box, you have the median nerve and 9 tendons. Those tendons are responsible for flexing or bending your fingers. When there is too much pressure in this closed system, that's when you have nerve irritation. Many people ask me, what causes this? And generally, anything that increases pressure in the carpal tunnel or take up space in the carpal tunnel can cause carpal tunnel syndrome. This can be caused by swelling in the lining of the tendons. It can be caused by joint dislocations or fractures, arthritis and bone spurs that put undue pressure on the nerve, fluid retention. This can happen in pregnancy, and many women experience this. This can also be caused by cysts or tumors in the carpal tunnel, though this is very rare. There are some medical conditions that are also associated with carpal tunnel syndrome, and they're listed here. They're not necessarily caused by it, but people who have these conditions have increased incidences of carpal tunnel syndrome. One question I get very frequently is if typing causes carpal tunnel syndrome. This has been studied for more than 30 years and several investigations going into this. At the end of the day, there's insufficient evidence that computer work causes carpal tunnel syndrome, but it can certainly aggravate those symptoms. We do know that regular prolonged use of handheld power vibratory tools, such as a jackhammer, almost double your risk of carpal tunnel syndrome. Similarly, prolonged, highly repetitious flexion extension of the wrist, especially with a forceful grip, can also cause increased risk of carpal tunnel syndrome. There are several things that you can do to decrease or mitigate these risks, such as taking frequent breaks, changing the stations in an assembly line, for example, to mitigate these risks. Now we'll go into what does carpal tunnel syndrome feel like? What are the symptoms one can expect? The 2 main symptoms that people will complain to me about are numbness and tingling and weakness in the hand. Numbness and tingling may feel like pins and needles, a fuzzy feeling in the hand, almost like a staticky feeling, or it can just feel oddly swollen. Most often, these symptoms are worse at night and may even wake you up, causing you to shake out your hand or laying your hand over the side of the bed. Over time, people may also experience a loss of dexterity or strength in their hand. Again, these symptoms will occur mostly in the median nerve distribution. That means the numbness and tingling will be in the thumb, index, long, and half of the ring finger. If it is happening globally in the hand, we have to look for other causes that may be contributing to the numbness and tingling that you're experiencing. Now you may ask, why is it that repetitive activities or sleeping may aggravate symptoms? The symptoms are often position or activity dependent because the space within the carpal tunnel changes depending on wrist position. So in the diagram on the left with the green checkbox, the wrist is in a neutral position. It's straight up and down. If you bend your wrist down or extend your wrist back, either of those extremes decrease the amount of space in the carpal tunnel. So oftentimes people have symptoms at night when we're sleeping in a curled position or on the phone for a long period of time with your wrist extended, because it is relatively decreased amount of space for the nerve to breathe. As carpal tunnel syndrome progresses, symptoms generally become more consistent. So in the early stages, like we had talked about, it's mostly nighttime pins and needles, numbness and tingling. You wake up, shake out your hand, and you go back to sleep. As it progresses, you can start having daytime symptoms, particularly if you're doing repetitive activities like we talked about, or activities with your wrists held in extremes of range of motion. In the late stages of carpal tunnel syndrome, you can have constant numbness and unfortunately can have weakness in the hand because that muscle is not getting the signal it needs from the nerve. It's important to realize that there are many causes of numbness and tingling in the hand, so one must not get tunnel vision thinking about carpal tunnel syndrome. Specifically, nerves travel all the way from the spine, as demonstrated here, and travel down the arm. A nerve can be pinched in any part along its course as it travels into the hand, and it can be pinched in more than one spot. This is something called double crush syndrome. So if someone is complaining to me that they're having neck pain or pain that is shooting down from their neck into their arm, down into their hand, I'm looking more at the neck cause of their numbness, tingling, and pain. Next, we'll go into how we diagnose carpal tunnel syndrome. So when I meet you in the office and after we go over your symptoms, I'll learn about how long they've been going on, their frequency, if they're getting better or worse, things that make it better or worse. Next, I'll go into my physical exam. I start off with a very thorough neurologic exam. I look at your neck, looking for signs of pinched nerves in your neck. Then I test the strength in many different muscle groups, those innervated by the median nerve and nerves in the surrounding areas. I then check the sensation in different nerve distributions to see if there's abnormal sensation from nerve pressure. In these diagrams, this is showing a test looking for pinched nerve in the neck. Here, I'm looking at the strength of that muscle at the base of the thumb that is supplied by the median nerve. And in the bottom figure, this is an instrument that I use that looks at the ability of a nerve to distinguish between one or two pokes. Along this wheel, those two pokes are getting farther away, and as a nerve becomes under more pressure and loses its function, it loses the ability to distinguish between two different pokes. They must be very far away to distinguish between the two. Next, I look carefully at the hands for signs of muscle wasting. If a nerve is under pressure and the downstream muscle is not getting that signal, the muscle will start wasting. In this example, you can see that the muscle at the base of the thumb is very flattened and it's even sunken in. This is a sign of severe carpal tunnel syndrome. Again, this is a reminder of the first diagram we looked at of the muscle being innervated by the median nerve. Next, one of the most important parts of the physical exam are provocative tests. That means we are trying to provoke the symptoms of carpal tunnel syndrome. We do this by superficially increasing the pressure within the carpal tunnel. First is with the Tinel sign. I would tap on the course of the median nerve, and a positive sign is reproduction of numbness, tingling, or even electric shocks into the hand. On the other side of the screen is something called Phalen's test. It is when the wrists are held in a hyperflexed position for more than 60 seconds, and I'm looking for reproduction of numbness and tingling. Like we had talked about, those extremes of wrist range of motion decrease the amount of space in the carpal tunnel and can reproduce the symptoms. The most sensitive test is demonstrated in the middle, where I put pressure on the carpal tunnel and I flex the wrist. All of these tests are performing the same idea of trying to increase pressure in the carpal tunnel and seeing if the symptoms are reproduced. And I go through all of this because we know that carpal tunnel syndrome can be diagnosed based off of getting a good history from a patient and a thorough physical exam. The American Board of Orthopedic Surgery came out with a strong recommendation that you don't need to get a specific nerve study to diagnose this. You can look at the symptoms and based off of this score, determine how probable is it that you have carpal tunnel syndrome. You may, however, be asked to get a nerve study from one of your doctors, and I often do get them still. We'll go into why now. A nerve study has two different components to it. One looks at the conduction velocity, meaning how quickly is the nerve transmitting a signal. The second part is looking at how does the muscle downstream of that nerve respond to the signal, and is it doing so appropriately? This can give you very helpful information to see where a blockage may be, similar to a traffic jam. So if I have pressure on the nerve, it will take longer for the signal to get across that area of where there's pressure. If a muscle is not receiving a signal and is waiting around for that electric signal from the nerve, it eventually stops responding. It falls asleep. That's when you start seeing muscle weakness and muscle wasting. The electric nerve studies can give us some helpful information to see where on the spectrum somebody may be if they are not fitting into the classic description of carpal tunnel syndrome. I also consider this when I suspect that there are multiple sites of compression in multiple different nerves to help us better target what is exactly the main driver of your symptoms. I may also be looking for this to see how likely is it that you would benefit from something like surgery. If the muscle is asleep, like the guy on the right, it may not wake up, even with a carpal tunnel release, and it's good to know that beforehand. On that note, we know that the longer a nerve is compressed and the more severe the compression is, the less reliable the recovery of sensation and strength is after a carpal tunnel release. If I were a patient going into carpal tunnel surgery, I would want to know that beforehand. So it's a long conversation that I have with people often. We also know that if there are multiple points of pressure on a nerve, coming from all the way from the neck and at the carpal tunnel, those patients do not do as well after surgery for carpal tunnel release, unfortunately. And it's good to know that beforehand so we can set expectations. Next, we'll go into how we treat carpal tunnel syndrome. Treatment is guided by how severe your symptoms are. So if you have mild symptoms, again, mostly nighttime symptoms that go away when you shake out your hand, the first thing we do, non-invasive, non-operative, is a wrist brace. The goal of the wrist brace is to keep the wrist in a straight position with a metal insert and avoiding wrist flexion or extension at night that can decrease the space the nerve has in the carpal tunnel. Some studies suggest that up to 80% of people can have some of their symptoms alleviated with just this measure alone. It's a great first step. You can order this on Amazon. We have it here in the office too, and it can be very effective with a very low risk. If symptoms are not getting better with this, next steps may be an injection. This is something that I do in the office. I use line marks on the wrist to identify where the carpal tunnel is. I inject numbing medicine and steroid into the carpal tunnel to decrease inflammation around the nerve and decrease the symptoms. So because the nerve would have more room to breathe. We know that patients can get up to 1 year's relief of their symptoms with a carpal tunnel injection. Studies show that it is less long-lasting than surgery, which does make sense. If you're having moderate symptoms, that is now having more daytime symptoms, but not necessarily weakness, can consider an injection. Definitely the wrist braces can't hurt. And some people are offered surgery at that point. If they try the braces, the injections, and they're showing signs of moderate carpal tunnel syndrome, it's reasonable to consider surgery for that if their symptoms are not improving with non-operative measures. In the cases of severe carpal tunnel syndrome, surgery is offered to relieve symptoms, but mostly to stop progression of any nerve damage that's happening. Again, here's the diagram of the carpal tunnel. We've talked about the floor and the sides of the box, as well as the roof of the box. The goal of treatment in surgery is to release the roof of the carpal tunnel. Now the nerve is not under pressure within a confined system, so it has more room to breathe. Now we'll go through how carpal tunnel release is performed. First thing we have to do is determine whether or not you want to be awake for surgery. We can do the procedure while you're awake and giving you numbing medicine. We can do this without a tourniquet or with a tourniquet. Without a tourniquet is something called Wallant. It's wide awake, local anesthesia, no tourniquet surgery, and it can be very effective for this. If you decide to have carpal tunnel syndrome awake, you can avoid needing preoperative medical testing. You can drive yourself home even after in some circumstances. If that is not your cup of tea, some people wish to have some sedation medicine when they're undergoing carpal tunnel release. If you have medical problems, you may need blood work and medical clearance before undergoing this. The surgery itself can be performed in one of two different ways, either open or endoscopic carpal tunnel release, and we'll go over the differences between the two. An open carpal tunnel release is performed by releasing the roof of the carpal tunnel from the outside in, meaning a 1.5 to 2 centimeter incision is made in the palm of the wrist. Dissection is taken down to the level of the roof of the carpal tunnel, and it's released from the outside in. This is in comparison to endoscopic carpal tunnel release, when a cannula demonstrated here as the gray is inserted into the carpal tunnel, a camera is used in the cannula, and a knife is deployed within the cannula to release the roof of the carpal tunnel from the inside out. I often get asked, which one is better? I offer both. Studies suggest that endoscopic carpal tunnel release does get patients back to work earlier. There's a slightly higher risk of nerve injury with this, most often a temporary nerve injury. But we know that after 3 months, there's no difference between the two. I've trained in both endoscopic and open carpal tunnel surgery, and it's a long discussion I may have with you when we're weighing risk and benefits of both. What does a day of surgery look like? You arrive at the surgery center or the hospital, you undergo the procedure, you spend some time in recovery, and then you're discharged home. The procedure itself can take less than 10 minutes. It is, however, a few hours process by the time you get there, get checked in, have the procedure, recover, and go home. You go home that day, and I advise people to take anti-inflammatories like NSAIDs and Tylenol. I do not prescribe opioids regularly for this. This was a study done out of Rothman where people were randomized into getting narcotic pain medicine or anti-inflammatories after carpal tunnel release, and there was no difference in pain control. So avoiding narcotics, definitely a good goal to avoid the risks of those medications while still managing your pain with Tylenol and ibuprofen. People after carpal tunnel surgery can expect to have pillar pain. That's soreness that is demonstrated between these red lines here. You can have scar sensitivity. It can be thick and tender, little sore to press on, and you can have stiffness afterwards. Generally, all of these symptoms go away with time, but they can last up to 3 months in some people. People ask me often, when can I return to work? It depends on what you do for work. The day of surgery, you have full motion of your fingers. You can type. I just ask that you do not lift anything greater than 15 pounds for 6 weeks. We know that the skin will take about 2 weeks to heal, and we just want to give some rest to the tissues. There are studies that suggest that splinting after carpal tunnel syndrome, carpal tunnel surgery doesn't change outcomes. So I don't ask that you wear a splint, but I do ask that you don't stress the area. You can drive immediately after as well, as long as you're not taking any pain medicine or had sedation from the surgery. Most importantly, people will ask me, when will my symptoms resolve and or improve? Again, it kind of depends. If you have mild carpal tunnel syndrome, mostly an issue with the blood supply, remember, those little blood vessels are within the layers of insulation. As soon as the nerve is released, you may have immediate relief of your symptoms. I had one patient who was awake during her procedure, and she said, "Oh, I know you finished it because I feel so much better now." That's an exceptional patient. Generally, I tell people to expect their symptoms to improve in less than a month if it's just a blood supply issue. If you have more moderate carpal tunnel syndrome and the myelin or the insulation around the nerve is damaged or thinned, we know that that takes about 3 to 4 months to improve. It doesn't mean that you won't feel any improvement until then. You can have some gradual changes over that course of time, but in about 3 to 4 months, you should know where you would be. If you have severe carpal tunnel syndrome and there is nerve damage to it, we need to wait for that nerve to regenerate. And nerve regeneration occurs at 1 inch per month. So to get from the level of the carpal tunnel to the fingertips, you have to calculate how long that would take you. When we get to that point, a severe carpal tunnel syndrome, our goal at that time is to stop progression of the symptoms and stop nerve damage, not necessarily to resolve all of the numbness, tingling, and weakness. In general, in the less severe cases, I tell people to expect the tingling to improve, especially the nighttime symptoms that are waking you up. Then gradually, numbness will get better, and lastly, strength will come. I hope this was helpful to you and gave you a better understanding of carpal tunnel syndrome. I am happy to take any questions.
Thanks, Dr. Tadley. There were a few questions that came in, so I'll go ahead and start from the beginning. So the first one is, I had carpal tunnel syndrome surgery 26 years ago. I have it again. How is that possible?
That's a great question. I'm sorry you're experiencing it again. This is actually something that we are looking into at Rothman, performing studies with ultrasound, because we know that that ligament that forms the roof of the carpal tunnel can reconstitute, it can regrow. So if it happened, if you had carpal tunnel release 26 years ago, over time, it can reconstitute and you can have recurrent carpal tunnel syndrome. You can still benefit from the measures that we talked about, and you can get relief again, hopefully for a long amount of time like you did before.
Thank you. There were a couple questions with similar. So, does carpal tunnel syndrome sometimes or often occur along with other hand disorders such as trigger finger? And off of that, is trigger finger similar to carpal tunnel symptoms? Are the symptoms similar?
The symptoms are a little bit different, and I'll go through what trigger finger is. The answer to the first question is that there are medical conditions that are associated with both of them. There is a common denominator. Those can be hypothyroidism and diabetes. Both have increased risk of carpal tunnel syndrome and increased risk of trigger finger. The issue with trigger finger is at the level of the tendon that is responsible for bending your fingers. Those tendons travel through pulleys or tunnels at the joints of your finger to keep the tendons close to the bone. If there's swelling in the tendon as it's trying to glide through those tunnels, it gets stuck, and then you feel that popping sensation. So unlike carpal tunnel syndrome, where it's a problem with the nerve having too much pressure, this is a tendon issue. Often an analogy that is helpful is thinking about a shoelace going through a straw. You can normally glide through easily, like a tendon would glide through the tunnels easily. However, if I put a knot through the shoelace and I try to pull it into the straw, it can get caught or stuck, and that's the painful popping that you have. It's often treated with an injection, and usually do 2 injections before considering surgery for that. What we do is release the roof of the tunnel as it starts, so similar in carpal tunnel syndrome that way, but we're targeting tendon gliding in that case.
Thank you. If you do not do surgery, will you lose function of your hand?
I don't know the answer to that question, but you may. That's the short of it. We know that carpal tunnel syndrome, if it goes on for too long and is severe, you can have nerve damage from it and loss of function in your hand in terms of numbness, tingling that may not go away, and loss of strength in your hand as the muscle doesn't get the signal. You don't necessarily know the rate at which the progression happens. If you have mild carpal tunnel syndrome, it may stay mild. If you have moderate or severe, we know that the nerve is under too much pressure and may have nerve damage, but everybody's a little bit different. It is something worth not ignoring, though, and checking in with a hand surgeon to make sure that you're not having signs of nerve damage, namely muscle weakness or severe numbness or decreased sensation in the hand.
Thank you. Next question is, does physical therapy have any role?
It can. There is a role for nerve gliding exercises. I find this to be helpful in more mild cases. And what it does is encourage the nerve to glide within the carpal tunnel so it's not getting stuck in a position that can aggravate those symptoms. Generally, what I would recommend is seeing a hand therapist. So this is a physical therapist who did extra training just to work on hand problems, and they can show you these exercises and you can do them on your own. These plus the other things that we talked about may be helpful. If you have very severe carpal tunnel syndrome, it is not likely that that would help your symptoms much.
Thank you. I sleep with my right hand under my head on top of my pillow. What, if anything, is that doing to the carpal tunnel? Also, I seem to have arthritis in my right thumb, but might it be carpal tunnel syndrome instead?
If you sleep with your hand under your head on the pillow, if it's in a straight position, it's not necessarily increasing the pressure in the carpal tunnel, but the weight of your head, maybe. It could be worth trying a brace at night if you're having nighttime symptoms of numbness and tingling that are waking you up. If you are having arthritis at the base of your thumb, that is a common place to have arthritis, where the cartilage at the ends of the bones is wearing out, and that is mostly characterized by pain and not so much numbness and tingling. Pain would be aggravated by gripping activities such as opening a jar, opening a bottle, or the medicine caps, pinching a key. Those things can aggravate arthritis at the base of your thumb. Questions kind of delineating your symptoms. Is it more pain? Is it numbness, tingling? Can help us determine if it's mostly symptoms from arthritis or if it's more due to nerve pressure from carpal tunnel syndrome.
Thank you. Go to the next. There's quite a few that came in.
Okay.
Um, I have a thumb that droops and is numb. A hand surgeon said he thinks I have a ruptured tendon in my forearm. Is this comparable to carpal tunnel?
I have a few more clarifying questions about that. If a thumb is drooping down this way, that can be due to a rupture in the tendon that's responsible for extending your thumb or doing the thumbs up. It's called the extensor pollicis longus, and it does start in the forearm. So if there was a injury to the forearm, a laceration or a cut in the tendon that could cause it, it is often or it can also be caused by different forms of arthritis or even wrist fractures, but it is not necessarily due to carpal tunnel syndrome.
Thank you. How many cortisone shots can you have before surgery is necessary? I am a Rothman patient and have had 2 shots so far, but symptoms are starting to return.
That's a great question. I hear this often. We do not like to do multiple injections in the hand over a short period of time. And the reason is that the steroid that we use over time can have negative effects on the tendons and the structures. It can also even actually cause rupture of the tendons. So I take it on a case-by-case basis. If I give someone an injection, whether it be for carpal tunnel syndrome or trigger finger, and they get a year's relief of their symptoms, we can restart the clock. But if you're coming back to me saying I had 1 day relief or 1 week relief, it doesn't make sense to keep doing multiple injections because you're getting the risks of the injections without the benefits of it. So generally, I like to do about 2 injections before we start thinking, should we do something that will give you more long-lasting relief of your symptoms? That being said, everybody is different. So if somebody has many medical problems or life just is not allowing you to take time to have surgery right now, we can work with you and take it on a day by day, a case by case basis to see what will be best for you.
Thank you. What is done if the patient only has symptoms related to the ulnar nerve?
The ulnar nerve can get pinched in the similar way to the median nerve is pinched. The most common place for that to happen is behind the elbow. So many of us have experienced hitting our funny bone and it sends an electric shock going down into the small finger. That is the ulnar nerve getting irritated. And if the ulnar nerve is under pressure at the level of the elbow, this is something called cubital tunnel syndrome. There are things like braces that keep the elbow straight that can relieve the tension on the nerve. You can also try injections around the nerve under ultrasound, but Surgery for that would require a cubital tunnel release, where we release the roof of the cubital tunnel behind the elbow. And sometimes the nerve is moved after that to put it in a position where it would not be under too much tension.
What about CMC thumb joint problems? Are they related? Treat it in a similar manner.
CMC thumb joint problems is most often an arthritis problem. So actually, if we look on the screen now in the thumbs up position, I'm pointing to, hopefully you can see my mouse, the CMC joint. And that is at the base of the thumb. It's one of the most common places that we see arthritis because of the amount of force that the thumb sees, particularly during pinching activities. It is increased by magnitude factors compared to the rest of the hand with pinching activities. So it's very common to have arthritis there. Again, most of the time, those symptoms are aggravated by pinching activities, opening jars, twisting activities that put a lot of pressure on that joint. Like arthritis in other parts of your body, treatments are first non-operative, non-invasive, like anti-inflammatories and bracing. The goals of both of those are to decrease inflammation and stress on the joints. As your symptoms progress, or if they do, next steps would be to consider an injection. An injection delivers steroids to the joint to decrease inflammation and relieve symptoms. It does not restore the cartilage. It does not prevent the arthritis from progressing, but it decreases the amount of pain that you have. If that does not relieve your symptoms enough, and your symptoms are affecting your day-to-day activities, your hobbies, your job, you can't sleep, and it is very severe, then you can consider surgery for that, but it is different than carpal tunnel surgery. It's a much more extensive surgery and extensive recovery.
Thank you. Somebody said that they are a wheelchair user. Do I understand that it will be 6 weeks before I can transfer into and out of my chair after surgery?
Great question. I would want to avoid direct pressure over the palm. So perhaps we could work together to figure out transfers perhaps on your elbows to offload that area, or even if you're able to do it on a closed fist so that your knuckles are seeing the pressure and not your palm, that would protect the incision and allow it to heal a little bit better. So hopefully it wouldn't be 6 weeks of not having transfers that you can do on your own. We would work together to figure that out.
Thank you. Can you cause carpal tunnel or any other hand disorder by playing pickleball several days a week?
We are getting a lot of pickleball patients in the office these days. I'm eager to try to play myself, but a little cautious because I'm seeing so many people in the office with pickleball injuries. But any repetitive wrist motion can possibly contribute or aggravate your carpal tunnel symptoms. It would not necessarily be caused by pickleball, so I don't want to offend the pickleball associations there, but it can aggravate those symptoms because of the repetitive wrist activities. Things like using a brace while you play may mitigate those symptoms.
Thank you. This person says they have de Quervain's and syndrome and carpal tunnel. How are the two different? They'll be having surgery to repair both.
So de Quervain's is an issue with tendons. So the two tendons that are responsible for bringing your thumb up and to the side travel through a tunnel on the thumb side of your wrist. They can be aggravated by repetitive activities. Many times, new parents get this from lifting up children or any kind of repetitive activity that brings your thumb in an abducted or away from your hand position. With de Quervain's, the inflammation in the tendons causes the symptoms. It is treated sometimes with injections to decrease inflammation. And if that doesn't work, the surgery that you may be having is a first dorsal compartment release, where they release the roof of the tunnel where the tendons are traveling. It is similar to carpal tunnel in that an area is under pressure and there is a roof to be released. But again, this is a tendon problem and not a nerve problem. Carpal tunnel syndrome is when the nerve is under pressure.
Thank you. There's a few questions about braces and gloves. So, like, do compression gloves help relieve minor symptoms? Someone who knits said that would wearing a glove be helpful? Is wearing a brace effective? If so, how often? So, I think they're both kind of similar questions.
Mhm. Sometimes a glove can be helpful. There are different gloves on the market, and I encourage people to continue to use them if they feel like they're helping their symptoms. It is not necessarily changing the amount of space in the carpal tunnel if you're putting on a soft brace or sleeve. The goal of the wrist brace is to have a rigid structure, that metal insert, that will prevent the wrist from going down or bending back in the extremes of position to keep the space in the carpal tunnel the maximum it can be. So while gloves and sleeves won't necessarily hurt it, I do feel that braces are more effective in treating it. So one thing to try is if you're knitting, you can put on the brace, see if you can still do the things that make you happy wearing the brace. And if it improves your symptoms, then I would wear it during those activities.
Thank you. Is it usual for carpal tunnel to be in both hands, and do you treat both at the same time?
Yes, it is common to have carpal tunnel in both hands. I do not treat them at the same time with surgery. And the issue is that you need to keep your hand clean for 2 weeks while the incision is healing. That is dry with a wrap on it while the incision heals. And if we do both hands at the same time, you do not have a hand to use for hygiene purposes. And there have been studies that show an increased risk of infection when you're doing bilateral carpal tunnel syndrome surgeries. Some providers are comfortable offering that. I am just not. So I recommend having them done in stages. So recently, I helped a young woman who had carpal tunnel syndrome in both hands. We did one surgery, and after 6 weeks, when she wouldn't have any restrictions, we did the other side.
Thank you. There's a question on PRP injections. Are they safer than a steroid injection, and are there any benefits to them?
I have not seen validated double-blinded studies that I feel comfortable recommending PRP injections for carpal tunnel syndrome. I think that the research is developing and it's out there and it's helpful for many other conditions, but it's not part of my routine practice to offer that for patients.
Thank you. Just going through a couple of these here. There's a few, so trying to get to all of them, but let's see. This person said she's a candidate for shoulder replacement surgery, and she's wondering if that condition affects her carpal tunnel. Are they related at all?
I do not think so. I don't think they're related. They can both be happening at the same time, and certain positions that you may be in after the shoulder surgery with your elbow bent or your wrists in certain positions can aggravate nerves, and it may aggravate your symptoms, but they're not necessarily related.
Thank you. Besides clinical exam, will MRI of the hand help in diagnosis?
I obtain an MRI of the hand if I think that there is something in the carpal tunnel that is contributing to the pressure on the nerve. So I have seen cases where there are cysts or tumors in the carpal tunnel, and an MRI is helpful in evaluating that. There is also a role of ultrasound. Some people are getting ultrasound to look at the diameter of the ulnar nerve. I'm sorry, the median nerve at the level of the cubital tunnel, and sometimes the ulnar nerve. Because when there's increased pressure, you can imagine that the diameter of the nerve decreases, and it can be used as a diagnostic aid in carpal tunnel syndrome. What people like about it is that it is not invasive and there are no needles like a nerve study would be. So it is becoming part of the routine practice in many offices, less so than MRI.
When numbness is experienced during driving/pushing a shopping cart, do you think that that is a part of the mild or moderate category?
If you're having daytime, I'm thinking you are approaching more of a moderate category. one of the physiatrists I work with, Dr. Friedman. We work together frequently and go over nerve studies together. He often will distinguish something in terms of its severity electrodiagnostically, what it looks like on the nerve study, and clinically. So somebody may have severe clinical symptoms. They're describing very severe symptoms of carpal tunnel syndrome, but we get the nerve tests and maybe it's moderate or maybe it's mild. So if you are having daytime symptoms, I generally put you in a moderate category, but there's some wiggle room there.
I've been diagnosed with slight carpal tunnel syndrome, and I also have already had cervical spinal surgery. They're having tingling again. It just recently started extending into my forearm. I've done physical therapy too. What next?
I would consider first, when are you having the tingling? If it's mostly at night, a nighttime brace can be helpful. It can also be helpful to have an injection. Injections can give us both therapeutic value, it can relieve your symptoms, and diagnostic information. If your symptoms go away after an injection, we know that most of that is coming from the carpal tunnel itself and not other areas of either nerve damage or pinched nerves elsewhere. So what I would recommend in that scenario is most often an injection.
I have pain on my right hand at the bottom on the left side. This pain has been getting worse for over a year now, but they recently had spinal fusion surgery, which helped their right arm and neck pain in December, but not the pain in the hand. And they don't know where the pain is coming from. They're right-handed and use the computer all day long, and they're having some numbness as well. So what would you recommend for that type of situation?
If you're talking about the right hand on the thumb side by the left side, it's hard to say. If it's mostly on the thumb side, I would look more towards the carpal tunnel. If it is on the pinky side of the hand, I would look to the cubital tunnel at the level of the elbow. We could do targeted injections, similar to the last question, to get both therapeutic and diagnostic information to see if what we're targeting with cortisone injections is improving the symptoms, then we know that that's usually the source of the issue.
Thank you. What is the difference between carpal and radial tunnel?
Radial tunnel syndrome is when the radial nerve is under pressure. That can happen at the level of the forearm here as it's traveling through muscles and some fascial bands. It is often characterized mostly by pain and not necessarily numbness and tingling.
Thank you. I read about stem wave technologies being used to help reduce inflammation and increase blood flow. Can this be used to help carpal tunnel or trigger finger? What are your thoughts on that?
I don't know much about stem wave technology. If it is something that is increasing blood supply, it could potentially help with that. But I would need to look more into that. I don't know.
Thank you. Um, when my carpal tunnel flares at night, the pain often extends up my forearm. Is this a signal that the nerve is being squeezed elsewhere than at the wrist?
That's a great question. It is possible to have traveling pain or radiating pain from the carpal tunnel up or from the carpal tunnel down into the hand. It can go in either direction. Not necessarily that is getting pinched somewhere else in the forearm, though it is possible. Generally, if you have a pinched median nerve in the forearm and not the wrist, the symptoms are a little bit different. You can have pain and weakness more so than the numbness and tingling based off of where the nerve is getting pressure on. But if you're having electric-like shocks that are shooting up from the wrist into the forearm, that can happen with carpal tunnel syndrome and is not necessarily a measure of other sites of compression.
Thank you. Are any of the electronic devices advertised helpful with healing after surgery?
I wonder what electronic devices, things like, it depends. So there are bone stimulators that are helpful for bone healing. I do not know of other devices that would help after carpal tunnel syndrome. Sometimes there are TENS units, which are electronic devices which stimulate nerves, and this can be helpful after nerve injury or nerve surgery if there is nerve damage and you are having what is called neuropathic symptoms. Neuropathic symptoms is abnormal excitability of the nerve. So you have burning, numbness, tingling, and pain that is not going away from neuropathy. And what TENS signals can do, or TENS machines can do, is kind of desensitize you to those painful stimuli. I don't know if those are the electronic devices you were talking about, but hopefully that clarified some things for you.
One question is, I was told I have pseudo gout. What is it? Is that similar to carpal tunnel?
Pseudogout is an inflammatory arthritis where there are crystals that form within the joint and cause pain. It is different than gout because the crystals are different, but same kind of idea behind it. The crystals are deposited within the joint, and that causes an inflammatory or inflammation response. It can be really painful, cause swelling and warmth in the wrist. This is different than carpal tunnel syndrome. This is happening inside of joints.
I've been diagnosed with carpal tunnel, a pinched nerve in my neck, and arthritis. How do I know which is the real cause of the pain in my hands?
Well, I'm sorry you're going through all of that. That sounds really uncomfortable. What I would recommend first is injections. Because injections target a limited area, you can see how much relief you're getting when we treat that area. We would not do multiple injections in multiple places. We would do this serially in stages to see when we target one of the areas that may be causing you pain. If we can relieve those symptoms, do most of your symptoms get better? That can help us figure out what is the main driver of the pain that you're experiencing. In general, if you have a pinched nerve in your neck and a pinched nerve at the level of the wrist, we generally start kind of distally, meaning towards the fingertips, and work proximally. As we had discussed, while no surgery is without risks, the surgery for carpal tunnel syndrome has less risks than surgery for your neck. So generally, we start addressing things at the level of the wrist first. And if you're still having persistent symptoms, would then consider surgery for the neck. In regards to the arthritis, that we would target with injections and see if that gets better too. And hopefully that would, to relieve your symptoms.
Okay. I have trigger thumb with carpal tunnel. I'm diabetic and hypothyroidism. I've had one injection that lasted about 6 months before the symptoms returned. Should I consider surgery or try another injection?
I think 6 months is a decent amount of time to have relief of your symptoms. I would recommend a second injection. I tell people all the time, I love surgery. It's my favorite thing to do, but it's my job to make sure that we've tried all of the other non-surgical options to try to relieve your symptoms before we get there. Something like carpal tunnel syndrome or trigger finger, these are not life-threatening conditions. They're quality of life-threatening conditions. And while important to address, we should definitely try to optimize non-operative things first. So I think it's very reasonable to try a second injection, and hopefully we get long-lasting relief from that. If not, we know what we would have to do afterwards, and we have a reliable surgery to fix that.
Thank you. Are there any other strategies for bracing the hand, or I guess keeping the hand straight while sleeping if you can't sleep with a wrist brace due to discomfort?
I know that they can be uncomfortable. Some people tell me they wake up and the wrist brace is on the other side of the room. I haven't figured out a better way to do it. Sometimes elevating the wrist in general, it would decrease swelling in the hand. So you could try that, because we know that any kind of swelling or fluid pressure inside may also be contributing. So it's something that you could try. Otherwise, if that's not helping, then that's when I start thinking more about injections. If you can't tolerate the non-operative, non-invasive things, then we go into non-operative injection type of treatment.
Thank you. My symptoms started a few months after my broken wrist healed. Is that common?
It is common, unfortunately. Like we had seen in the other diagram, the floor and sides of the box are formed by the bones of the wrist. If you break your wrist and the alignment of those bones changes, you can have increased pressure within the system because it's changing the architecture or the amount of space the nerve has to breathe within the carpal tunnel syndrome. It is also possible that the swelling from the injury too can contribute to it. So when someone comes to me with a broken wrist, I specifically ask them if they're having numbness and tingling, if it's getting worse over time. There is something called acute carpal tunnel syndrome where it happens suddenly, and that can be something that we would need to address surgically. If the wrist fracture has healed and you're still having symptoms, or the symptoms are just starting now, we can still try the things that we've discussed in this webinar, non-operative, non-invasive things, consider injections, and surgery may be required for it, but there is an association sometimes after having a wrist fracture and developing carpal tunnel syndrome.
Thank you. We have time for one or two more. Thank you so much for answering all of these questions, Dr. Tadley.
Of course.
So one question from someone that came in. I only have had numbness in sleep noticed by awakening. Lately, none. I do various glide exercises. My physical therapist has determined mild loss of fingertip sensation, but I don't get pain from either my cubital or carpal tunnel. So our plan has been to get an EMG and move on from there to therapy or consideration of surgery. Would you think another approach might make more sense?
I think
That's
that is a
specific.
logical, it's a logical approach of assessing the health of the nerve, how the electric signal is traveling, if the muscle is responding to it. If you're having the numbness and tingling during the day or constant numbness and tingling, that tells me that there's definitely pressure on the nerve that, while it may not be causing you pain, is at least present enough to cause nerve dysfunction. You're welcome to come in. I can evaluate you and we can go over the EMG or the nerve studies together. But things to consider before surgery if the EMG does not show severe carpal tunnel syndrome are things like injections. And particularly if you have mostly nighttime symptoms, I would try the braces.
Thank you.
Mm-hmm.
Okay, one more question. There are a couple that came in. Well, I have neck disc problems treated by a chiropractor. My arm hurts on the side with the floppy thumb. How does the neck problem get treated to help the thumb? I don't know if that's really related.
It's hard to say. I don't know what is causing the floppy thumb. If it's weakness in the thumb, it can be because of a pinched nerve in the neck that the chiropractor may be treating. And if the signal from the neck is being blocked by a pinched nerve, then it's not getting to the thumb, causing thumb weakness. It can be addressed by treating the neck because then you would be relieving pressure on the nerve. There are other causes of floppy thumb that are beyond the scope of this talk, but that could potentially be the direction the chiropractor is going.
Thank you, Dr. Tadley. All right, so we ran out of time for questions, but you answered so many of them, and thank you so much for your informative talk this evening. Thank you, everyone, for joining. There were some questions that did come in. We did record this. We will be sending it out most likely by the end of the week or the weekend. If anyone has any questions or would like to make an appointment with Dr. Tadley, you do all have my email, so please feel free to reach out to me directly. I'm happy to help facilitate an appointment. And thank you again, Dr. Tadley, and thanks again, everyone. Have a great night.
Great. Thank you so much.
Thank
Have
you.
a good night.